Hi, my name is Akash Patel. I am a consultant trauma and orthopedic surgeon, and I work in London. And today we will be talking about knee osteoarthritis. So, the first question I get asked about knee osteoarthritis is what is it? What is osteoarthritis? So, osteoarthritis is a degenerative condition that can affect joints. It essentially involves wear and tear around the joints where the cartilage wears away. There are two broad components that can cause osteoarthritis of the knee joint. One is the genetics, and two is environmental. And the genetics we still don't understand yet because everyone is built differently, and we don't understand currently what the genetic exact cause is for osteoarthritis. But environmental things are essentially what we do to the knee. So, for example, if we injure our knees, we tear the bits of cartilage in the knees called the meniscus, which are like shock absorbers. If we get damaged playing sports, for example, if we damage the ligaments in the knees, then or fracture the knee, the probability of developing osteoarthritis increases. The next thing that I get asked by patients, what are the symptoms to be considerate of? So symptoms are usually pain, swelling, stiffness. Sometimes you can get giving way sensations as well, but usually pain is one of the commonest symptoms, and that can be around the side, the front, the back of the knee. And this is really important because we have to consider the function and how much pain limits patients before we make decisions of how to take the next step forward. Following assessment of course, your symptoms, we have to think about how do we diagnose osteoarthritis? What do we do as orthopedic surgeons? So, firstly, we take a history, we examine the patient, we undertake investigations, and then we talk about treatment options, which are always non-operative or operative. So, in terms of the history for osteoarthritis, the key symptom is pain, swelling, stiffness. Sometimes this is gradual, progressive. It can be chronic. If this osteoarthritis is severe, patients can get pain at night, usually around the whole knee. It can affect both knees, and that's key to consider. We also look at joints above, joints below, because sometimes patients come in with both hip and knee osteoarthritis, which can be interconnected. We also assess patients' medical background, any treatments that they've had, tablets that they're taking, and their function in terms of how badly this is affecting them. After we take a history, we examine the patients, we take a look, we feel, we move the joint, we take a look at the joint above, joint below, and we assess, of course, blood vessels and nerves around the leg, which can contribute to our decision making and treatments. Once we've taken a history and examined the knee, the next step forward is to undertake investigations. The commonest investigation that we undertake is an X-ray. This gives us an indicator of the degree of wear and tear. There are other investigations that can be done, such as CT scans or MRI scans, but these are very specific investigations, and we don't always need them. After we take a history, after we examine the patient and undertake appropriate X-rays, the next thing to discuss is treatment. So there are non-operative things, which include things like physio, which increases the strength, helps improve the balance, range of motion, flexibility around the knee, which is absolutely key. Whichever treatment road you decide to take, it's important to try the physio first and after. Second thing, activity modifications. We always talk about the importance of low impact things and moving the joint as you feel comfortable. So swimming, cycling, yoga, Pilates, walking, all good low impact things. Third, painkillers. So things like paracetamol or anti-inflammatories are usually low risk and they help to improve the symptoms. Fourth is lifestyle. So eating, drinking, sleeping properly, watching your weight and getting into good regular patterns and habits. So daily 30 to 60 minutes of good positive activity for the knee. Next step forward for arthritis of the knee are injections. There are three broad categories of injections that we undertake. One is steroid and local anesthetic that helps to reduce the pain and the inflammation. This does have a risk, so risks of bleeding, infection, swelling, and we don't like giving lots and lots and lots of steroids because they have a negative impact on the cartilage. So that's why we usually limit them to one injection every 6 to 12 months approximately. So the second injection that we give is platelet-rich plasma. This involves taking a sample of your blood and spinning it in a special machine called a centrifuge and injecting it back into the knee. Now, this is still experimental. It does not work in every single patient, but there is some data to support the use of PRP and early wear and tear around the knee. The risks are low for this, and it is an option. And then the final injection is something called hyaluronic acid, which is like a joint lubricating fluid, which is like oiling a car. And essentially, the data for this is still experimental. So again, this doesn't work in every single patient, but it's a low risk injection option, and it's lower risk than giving a steroid. So those are your injection options. The next step forward for knee osteoarthritis are things such as joint replacement. So we can undertake partial or total knee replacements. Both have their risks and both have their benefits. The benefits of these procedures are improving the symptoms of pain. The risks with any surgery: bleeding, infection, swelling, stiffness, scars, blood clots, heart, lung problems, anesthetic risk, and pain. We can never guarantee that we'll get rid of 100% of the pain following a knee replacement, but usually partial or total joint replacements are helpful to consider. The benefits of a partial joint replacement are that it's smaller surgery, the recovery period is quicker. The risks of partial joint replacement are that they can wear out or they can loosen quicker than a total knee replacement, which is quite tried and tested. And total knees can last 20, 25, even 30 years. The next thing to think about is, what is a knee replacement? What is a partial knee replacement? So these are components which replace the joint, which are made up of metal, plastic, and cement. And usually what we undertake is removing the damaged bits and putting in the cement, the metal, and the plastic. So in summary, these are good operations, but with knee osteoarthritis, we must consider the diagnosis, the history, the investigations, and these treatment options. In terms of a knee replacement, we have to talk about what actually happens with knee replacement. So patients are assessed by the anesthetic team first after we have undertaken a plan to undertake a knee replacement. Then they come into hospital. They'll have a spinal, which is a partial anesthetic into the back, or a general anesthetic where patients are completely asleep. They'll have the operation, which can take an hour roughly, and the patients will be up and about walking either the same day or the day after. And usually patients go home in 24 to 48 hours. The first few months, the knee is painful and swollen, but it does get better, and it can take up to 1 year for the recovery. And in summary, we've talked about what is knee osteoarthritis, we've talked about the importance of history, examination, investigations, and your treatment options. And the key thing is the rehabilitation and the physiotherapy following a procedure or before a procedure.